Good morning, everybody. Again, my name is Garrett Schmidt. I'm the managing editor for ACO Exhibit Hall. And I would like to welcome you all to today's webinar, which is part 2 of a 3-part series by HealthEC called Getting Your ACO Through the Crisis. And that is the series name. And today's session is called Recreating or Rethinking Your Risk-Based Contracts, How to Prepare for the New Normal. And this is a very timely issue right now, so we're really glad you joined us for today. I think it'll be very informative. A few items of note before we get started here. All attendees have joined the webinar today in listen-only mode, so you don't need to worry about muting your mic. That has been done for you. And I'd like to let you know that the webinar is being recorded, so you will have the opportunity to rewatch the session and or share it with colleagues, and we hope that you do. And I'm going to email all of you after the presentation to send you a link to where you can watch that the session and also download the slides. And you'll be able to use that link and access it later and share it. During the webinar, we want to hear from you. So please submit your questions to our presenters using your attendee control panel, and you'll see that on your screen, and you can submit the questions through there, not through the chat, but through the question module. And at any time, so you don't have to wait till the Q&A session at the end, but we're going to get through as many of those questions as we can during that Q&A session. And for those questions that we're not able to get to today, don't worry, we will email you and make sure that we answer those directly for you. So please, again, we would love to hear from you. Okay, without further ado, our presenters today are Dr. Jennifer Yeager, who's the Senior Medical Director for HealthEC, and also Dr. Sanjay Seth, who's the EVP CMIO for HealthEC. So I think Dr. Yeager is going to kick us off. So welcome, Dr. Yeager.
Thank you so much, and welcome everybody. Thank you for spending a bit of, well, here in Boston at least, a beautiful day with us. I'm going to start with, I think there's an agenda slide, and just sort of let you know what the next hour or so will be. So let's see.
Can you not see the slide up here?
No, I can't. Sorry about. Can you?
Are you able to advance the slide? Maybe it's on a delay.
Sorry.
No, that's okay. You know what? I'm going to just start well, with the slides catch up. I just wanted to give folks out there a little idea about who HealthEC is. Now, we've been in the healthcare IT space since the mid-1990s. Initially, we were the largest claims clearinghouse on the East Coast, and it was called MedLink. We were acquired in the late. Oh, all right. I'll go back to the agenda. So first, just the introduction. Then we'll be talking a little bit about recovery and what that looks like. And then Dr. Seth will take over and say, given where we are and where we may be, what do we need to think about just in terms of our risk-based contracts? And then we'll leave some time for discussion and questions. So Dr. Seth, the next slide. Terrific. So this is just a little bit about HealthEC. I'm not going to walk you through this entire slide, but just so that you know who we are. As I mentioned, we've been doing healthcare IT and population health for over a decade. We were initially the technology under MedLink, and they were acquired in the late 1990s, early 2000, and relabeled as MDON, which subsequently became WebMD, and then Change Health. We redesigned and redeveloped our platforms, working with United Healthcare, Siemens, and Johnson & Johnson in 2009. And at that time, we began running a clearinghouse called the Minnesota eConnect. So we've been doing this work a long time. In 2011 and 2012, we implemented regional interconnectivity with an enterprise master patient index, doing data analysis, and combined everything in about 2013 into a comprehensive population health management platform. So we have a good sense about data and how to move forward. We have become a QCDR MIPS registry. And in 2019, we were labeled best in class for population health management. And we work with a variety of stakeholders, from providers, both IPAs or hospital systems, payers, including CMS, state Medicaid agencies, and commercial payers, government, including Department of Health and Human Services for various states, as well as departments of public health. And we provide actionable data for these different populations, so you can monitor performance, you can design a strategy, and then measure your performance against that. We provide decision support as well as case management. So that's a little bit about us, and there's more data here, but what does that mean in terms of how we can address what's going on? So as I said, we collect a lot of data, and we're able to take a look at what's happening in the various spaces. I think the first thing to talk about here before we say how it's going to change is just to understand, what happened to healthcare, right? So pre-COVID, telehealth was pretty much non-existent, about 0%. And early in the pandemic, we saw an abrupt rise in the use of telehealth. So within first week in March, it was about 1%, and within less than a month, we saw telehealth increase to almost 20% of cases and a 60% reduction in ambulatory care visits. That's even greater among the surgical subspecialties. So surgery itself saw a 66% reduction in visits. And that's predominantly looking, of course, at elective surgery, which has a unique set of criteria compared with the ambulatory specialties. But when we think about where do we go, when people keep saying, well, when do we get back to that new normal, or when are we going to get back to where we were, and in terms of the impact of revenue on various parts of the healthcare system? And I would say, rather than look at when are we going to return to our baseline levels, I would say, should we return to our baseline levels? We should ask, can we serve our patients and members maybe better by incorporating telemedicine smartly and strategically? We're seeing now a return to provider offices as people are getting sick and tired of being isolated and putting off visits long enough. And so right now, ambulatory care is seeing on average about a 30% reduction from its baseline. And so in this last month, we've seen a real reduction in not just telehealth, but as a return to seeing folks in their offices. I would imagine that based on all of the forecasting and such that I've seen, and in taking a look at what people are saying in terms of what telehealth provides, that we won't go back to where it had been. It won't be an elimination of telehealth. But I do think that there, in some situations, we can encourage our patients to enjoy telehealth. We provide care coordination and good preventive health this way outside of a physician's office. You can reduce unnecessary ED visits and hospital inpatient utilization, improving patient satisfaction and outcome at reduced costs. So telehealth really is the answer, or an answer to the triple aim. And I have a whole bunch of other statistics I can talk about just in terms of how much care is unnecessary, anywhere between 20 to 40%, some studies will say, depending on what you're looking at. Providers will say 20% of overall care was unnecessary, and 40% of radiation procedures. And you can look at the patient satisfaction. Some reports even before COVID suggested that more than 75% of patients would be likely to choose a physician if they were offering telehealth. So there's good reason to want to pursue telehealth in the right setting, and certainly for preventive care, this is a good place to begin. But in order to do that smartly and be strategic, we really need to think about processes and issues that are different here in that space compared with in the office visit. And the first thing is here from a provider standpoint is sympathy and empathy, really. We lose a lot by being separate from the patient. There's no laying on of hands, right? We're not shaking their hand. We're not seeing their body language and the proximity of being with them in the room. And so we really need to be thoughtful and engaged and proactive in taking a look at how to establish our personal communication, our personal relationship in that space. And I really can't emphasize that enough. Communication or miscommunicating, right? That's another big issue. So first and foremost, we rely so much on body language, which we lose through telehealth. In addition, all of the senses other than our sight that we rely on even subconsciously. What's the color of the skin? Well, that's going to be hard to see depending on the lighting and sometimes in a small window, whether you're really going to be able to see, are they a little ashen or are they ruddy? What are you getting a sense of in that sense? The other is smell, and so there's a lot of senses that we rely on that we don't have when we're distant. In terms of retaining office discipline, right, and avoiding gaps in care. Again, we really need to make sure that there's good processes in place that support the flow and care coordination and referral and making sure that you are addressing all the issues that are there. There's a greater chance of interruption. So, you walk in, you close the door, and everybody knows you're in seeing that patient. When you're at home, perhaps, or they're at home, somebody comes to the door, their dog needs to go out. There's, I just closed my windows here in my study so that you wouldn't hear the lawnmower outside my neighbor's yard. Time also moves differently. So it's harder to judge that you're moving too fast. Like I may be talking too quickly right now. And because I can't see your faces and I'm looking at my screen and I'm seeing everything that I need to get through. And so as a provider, whether you're a care manager or a physician or nurse, you want to make sure that you're taking your time to give them a chance to respond, which I promise we will let you do as well. Out of sight, out of mind. You need to be careful not to be moving away from your camera. You drop something and they may not see, and then you bend down to pick it up, and now all of a sudden you're gone. Practice, practice, practice. I like to joke that physicians aren't very well trained in some really basic things like nutrition. I can tell you I got 1 hour of nutrition training in my 4 years of medical school. So we've not been trained in how to do this. And in fact, behavioral health assessments and mental health assessments, or what's called mental health first aid, for the most part, physicians and nurses don't get a lot of training in that. And so we need to be aware that there may be new things that we need to learn in order to be so effective and to encourage our patients to want to continue coming back to their telehealth. Compliance is another issue. And of course, right now we're getting reimbursed for telehealth, and when the pandemic is resolved, whenever that will be, CMS may change the rules again. So there are other things to consider at that point. And then here in bold is who plays the psychologist. And when I was speaking with Dr. Seth about this, he made a great point, which is when a person walks into the office, it's more than just for well care or an ill visit. This sometimes elderly or infirmed individuals are coming in for the social contact, and they see the person at the front desk who they see every so often, and they talk to each other, and there's a sense of well-being and of belonging. And then they go into the room, and there's the nurse who checks their blood pressure, and then there's somebody who checks their weight, and then finally, the provider, nurse practitioner, or physician will come in, and we're only one of a large orchestra of individuals who are having touch points with this individual. And so it's important to understand that with telehealth, whoever it is conducting the interview or the exam is it. And so they really need to play multiple roles. In terms of the processes that we need to design to be efficient and effective, of course, registration. we talk about co-pays or deductibles and payments. These things have to be worked out. Handoffs to other staff. Well, we call that referrals in telehealth, but you want to make sure that these referrals are being handled well and in real time and supported and followed up on. Again, practice, practice, practice. I think that can't be said enough here as well. Designing new protocols and communications will also be necessary. And then, of course, documentation either in something like a population health management platform that we provide or the EMR. And then in terms of the patient, again, we need to be cognizant that of establishing an emotional connection and a supportive connection. And how do we do the exam? So there, again, in our platform, we are Bluetooth enabled. So some of the smart devices like the stethoscopes and glucose monitors and blood pressure cuffs, if this were set up, we would be able to get these feeds. And so you'd be getting some of this information, but you're not going to be able to do the physical exam. And so you do need to find ways of addressing some things that may be coming up that you wouldn't want to defer.
Right.
Loss of personal interaction, we've talked about that, and a perceived lack of privacy. So one thing to consider is that although we lose the evaluation of the patient in front of us, where we're losing body language, or in my case, I'm a pediatrician, and so seeing how the child responds to the parent and how the parent reprimands the child, the two of them are in the office together, and so seeing, are they fighting, and what's the discipline? You learn a lot, of course. When they're in their home, you don't see that, but you do then see them, your patient in the home setting, and that may be felt as a bit of an invasion. And some folks may feel, in fact, that it's a deterrent for telehealth, and that could be problematic, particularly if, as we're seeing now with isolation, increases in domestic violence and sexual, gender-based violence, child abuse. We're seeing these increases, and it may be that folks who are at greatest need for having a touch point will actually refuse to have that telehealth visit. Technology barriers, of course, when you need to have a computer, it's a little bit harder to do it on a smartphone or a tablet. I suppose these situations can be set up in that way, but it would be better to have a computer, and not everybody does. And just logging on, number of video conferences all of us are having, and how many times are you not able to connect the first time, or is the sound garbled? And then again, compliance. It's one thing not to show up to the visit, and you can understand they've had to take 2 buses to get there, but people may just choose not to or may just forget through their day-to-day activities that they're supposed to, in fact, quote unquote, go to the doctor now, meaning go to the office, their study, and turn on the computer. So these are things that just in terms of how do we be thoughtful in an interpersonal and in a logistic and functional administrative way, encouraging telehealth where it's important. Next slide, please.
Dr. Yeager, I wanted to add a point that this morning's headline says that while we were thinking that access to care through telehealth was made available to everybody, but internet connectivity, broadband connectivity is playing a huge factor in not being able to do video and only end up doing telephone access. So I saw that as a headline this morning.
That's
so
perfect. Perfect addendum to this, absolutely. So in terms of recovery, the title here is Remain Conservative. And I think the takeaway here is this is a marathon, not a sprint. Don't try to do too much. Don't try to do too much too quickly. And where we may see a return to baseline or initially a rebound of trying to make up for lost, in this case, elective surgeries, with hopefully a return to the baseline. We know that the way we have been doing healthcare is in this country is unsustainable, and particularly with regard to ambulatory care visits and perhaps even elective procedures, not returning to our baseline might be the better goal instead. But in terms of how can we, what types of modeling or considerations would we suggest? So there are several forecasting models for the pandemic spread, and this is different than recovery models, but just to sort of level set, there are case projections and capacity planning, community vulnerability maps, and case mapping with projection tools. These are various types of forecasting tools that have been used and very useful, and it may actually be contribute to our understanding in terms of recovery from rebound in terms of our delivery of healthcare. But there are other ways of considering this as well, and there's a great reference, and I think we've included it here in your as a handout, is from the Healthcare Advisory Board, and they have 5 steps, and they're only one of a number of online sources that you can find now, but it takes into account 5 different steps for how would you plan for recovery. So one would be confirming that you can safely manage elective procedures. And you can think about that also from an ambulatory care standpoint. Can you safely manage patients coming back into the office? The components here would be know where you are on the curve. And that's important no matter what, whether it's, again, elective surgery or ambulatory care visits or procedure-based subspecialty visits. You need to be tracking cases, death rates, your doubling rates, which is a key metric, and your facility utilization and lab capacity. And I'm sure that your organizations have been tracking this all along. And as you see the numbers turning in the direction you want, whether increased or decreased, that's when you can start considering that now we're going to bring folks back in. You can also assess and need to assess facility testing and supply capacity. And this is COVID testing supplies, whether you need masks and personal protective equipment and swabs, but also other critical supplies, medications, et cetera, as well as your staff capacity. The second is determining how quickly to prioritize procedure volume. So you need to understand what the projected demand is going to be. So how many visits or elective surgeries, procedures were canceled, and what were your prior trends? And then assess the competitive environment. In Florida, they opened up perhaps quicker than they quote unquote should have, understanding that 75% of their economy had to do with tourism, and that's an important consideration. So they opened up quickly, and now they're seeing quite the backlash. They're calling it the second wave, although quite frankly, it's probably still the first wave. They just hadn't finished the first wave and didn't recognize that it was. But they are seeing a rebound, an abrupt rebound in cases. So,
Dr. Yeager, this is all in the handout that we are distributing, correct?
Yes,
Yeah,
absolutely.
Okay, so yeah, that's excellent.
So I will then just mention the last 3 steps, but won't go into them because, as Dr. Seth said, I'm being cognizant of time, that it's in your handout. But you'll want to take a look at developing and implementing new policies and procedures, re-engaging your staff, including attending to folks who've been furloughed and their needs, and then establishing your communication plans. But I think it's important to realize that we're going to get back to normal quickly is unrealistic and not useful to consider in that way. And that you need to understand here, and they're listed on the bottom chart here, what the barriers are for recovery, and then addressing those in an appropriate way. And I list most of these already. So I'm going to turn this over to Dr. Seth, and will be available for questions afterwards.
And thanks, Dr. Yeager. And what Dr. Yeager has been focusing on is that as we go into this webinar to address what the transition should be and how you should rethink your value-based or risk-based agreements, the capacity to handle cases should factor into that renegotiation on your risk-based agreement. I think we're still struggling with the uncoupling of payments and encounters, or revenue and volume. And I was looking up about how do I define uncoupling, and I came across this totally unrelated comment made by Catherine Woodward Thomas, who was supposedly a lifestyle guru for Gwyneth Paltrow, and coined this phase of civilized conscious uncoupling, or conscious uncoupling. And that is that we better make this decision to move to risk in a conscious fashion. Make it a conscious decision. Do not have it imposed upon you as something that you are now forced to do. And we can see that the whole concept of volume and encounters with telehealth, with how we're going to plan for the recovery, patient and provider behavior both have been affected. And I think we are beginning to see the emergence of less is more. And I think that fits right into our triple aim scenario, and where cost, quality, and outcomes need to be rethought as not standardized definitions as we have been using in the past. The whole redefining of access and quality, which really was that the driver? Were those the driver for patient satisfaction, and not really the frequency of encounters that were occurring? I think that's a new thought that we should all have in terms of what is really driving patient satisfaction, because retention of patients, which could have been expressed as a geographical need, may not be so anymore. So I remember in the days where transportation was a big issue, or is still a big issue in some places. If that's eliminated, how do patients then define for themselves whether they are satisfied or not? We are also beginning to see comments made by the payers that telehealth is more for convenience than actual access. And again, if that's the case, they could turn back the clock on telehealth, but at the same time, how are we going to then redefine patient satisfaction once again? So the idea here is for the providers to really strategize to what we think should have been retained control in this transition period, or regain control during this transition period. I mean, depending on where you are as an individual organization, this strategy should be thought through. And ultimately, whose processes, as Dr. Yeager brought up earlier on, both from the practice, provider, and the payer's perspectives, whose processes are really ready for this new environment? Is it going to be the provider or the payer? And this was a great article in last month in May in Physicians Practice, is that this author felt that COVID-19 demonstrated the need for independent physician groups, and I think it's just not independent, it's any physician group, to assert their authority against payers. We have been, as physicians, we have been unable to leverage individual strengths, but together there's a huge new paradigm that could definitely change our conversations with the payers. So the next slide is what we start talking about is what are the goals? So what are the approaches to risk-based or two-sided contracts? And sometimes the goals do not get aligned. And you can see that the provider's goal is to minimize risk taken from a revenue perspective, and share the burden. And question is, who do you share it with? And it's typically the payer. And on the payer side, it is to minimize risk and shift the burden of risk. So the payer is pushing the risk to the provider. The provider is saying, I don't want all the risk. And so there is the commonality is, or the common feature is, that we both want to manage risk. And so there has to be a balance between who's taking and who's giving or who's shifting. And I think the same is going to occur with the revenue. And this is why Dr. Yeager was talking about, is that with telehealth or with the cessation of all elective surgeries, revenue could be the focus for the next 6 or 9 months. And that could be the differentiator between a practice or a provider surviving and continuing operations, or then finding a way to guarantee their income by becoming employed. Either way, we need to maximize revenue, but the payer is looking to fix cost more of their fixed cost, or their greater percentage of their cost being fixed rather than variable. And maybe they've rethought that a little bit over COVID, because they have found that in this variable environment, they did make a lot of money and they had a lot of savings, and we have begun to see the return on premiums. So it may be a little bit of a timing issue, but eventually they want to fix more of their total cost of care. And so, but either way, both of us, providers and payers, need to manage costs. Providers want to get paid based on severity of illness, and the payer is saying, I'm only justifying the premium based on risk. I'm not justifying payments based on risk. And that's their position so far, where they do not want to take the risk as much. And both parties do think that providing the right care at the right time at the right location would make that different. However, the providers need to get away from thinking, how much of this should I move from a severity perspective? The next point is really a difficult one to answer, and the providers, generally, as we are in altruistic in nature, want to do the best thing for the patients, and sometimes it gets misguided. And when you come to end of life care, or being conscious of malpractice, and I think that's something that we should try and redefine for yourselves as a provider group. Or is the payer considering cheap and best alternative all the time? That is, what is the easiest way to get the delivery of care without having to increase cost? And the three angels in the middle are sort of smiling at overall, saying, yeah, you guys go ahead and fight as much as you want, but ultimately the patient needs to be the beneficiary. So when we get our act together, I think that would become an irrelevant posture for either one of the entities, providers or the payers. The third point, or the fifth point here is that be astute about what services you are going to contract for or take the risk for. Try and limit that for the services that are under your direct control as a provider group. Whereas the payer is saying they don't want any of that risk. They want to hand over the entire care. We still see a fair amount of division between mental health and behavioral health and medical care. And I don't know if that will change any in the near future. And so do we with dental care. But multi-specialty groups, large provider organizations are in a better position to talk about more than a single line of service. So that comes back to the previous slide where we talked about physicians do need to get together to have or to gain control. While we are doing this, we need to understand some of the relationships between services and cost. And again, this is just, this is dependent on time. This is dependent on circumstances. So it's not a hard and fast rule. This is not all or none. It is, but it is predominantly driven in this fashion. Inpatient care or acute care is a direct relationship to total cost. The more inpatient care, the more acute care that is offered, the higher the total cost of care. However, if you're in a relationship where the payer has negotiated a DRG based or a episode based or a fixed fee based contract with the inpatient care provider, they've capped their limits, but it's still direct. On the other hand, be very careful of the network that the payer is offering you as a provider group, where the inpatient care is on a per diem. And so makes a big difference on how you handle the need to control inpatient utilization. If it's per diem, there's less pressure. If it's DRG, there's much greater pressure on handling inpatient care or avoiding unnecessary inpatient care. Hospital-based outpatient services, as of now, it is certainly a problem, and it conflicts directly with the freestanding centers services below. And if you are in a relationship where they have, and we've seen this in some states where the payer has frozen the addition of freestanding centers, whether they are for dialysis or surgery or infusion programs, they are not adding any more providers, and that causes more of the services to be shifted to the hospital outpatient programs, where the costs and the reimbursements tend to be higher. So if you are in a current environment, is your contract for under total cost of care with those limitations, your freestanding center utilization, if it increases, the relationship to cost is inversed, because as you shift work from outpatient hospital-based services to freestanding centers, the cost is going to go down. Skilled nursing facility is a direct relationship, and it's a linear one. Again, in this situation as well, it could be inverse. If you participate in the 3-day waiver program, or you have commercial risk-based contracts where you're not forced to admit to the hospital prior to moving a patient into a skilled nursing facility, LTAC, a long-term acute or rehab facility, they could be great alternatives, and then that relationship does become inverse again. But I think that just be careful of that thought process, and you need to look at your contract for your entire network, not just for yourselves, because what happens outside your offices or your environment as patients seek care somewhere else could have an impact that you have no control over. On the professional side, other than E&M, all the other procedures, and this is where Dr. Yeager again brought up the high percentage of unnecessary procedures, imaging, lab tests, that we have typically found an excuse to have done. They are direct relationships to cost, except where we think that as E&M codes or E&M services, that is office visits and examinations by the providers, increase, the general utilization or unnecessary utilization of expensive alternatives as inpatient care, ER care, or hospital-based care reduce. And that is now evident very clearly with data, and I think it's the primary driving force for most of the contracts. Certainly home health and DME use has the same relationship as E&M. However, we have seen abuses and prosecutions related to both these in the CM world of CMS. So there is a very high propensity for abuse for both these services, which typically, as practitioners, we tend not to read the document put in front of us by these agencies to get signatures. And if we start putting motorized elevators and ramps and chairlifts in homes, it does become a cost factor. So be very, very careful. Otherwise, appropriate use of home health and DME can reduce the use of inpatient and acute facility-based services. Pharmacy utilization is absolutely a direct and linear relationship. So, avoiding brand name medications and watching even the prescriptions done by the referred to consultants is something that you should be careful of. And all of these will come back to us as I talk about in the next slide. Is what are the common things, phrases and terms, and the reference I was making to is the last point. What are we considering in our contract to be core services and optional services as something that we would offer? So here are some common phrases and terms. MLR, medical loss ratio, know how it's defined and calculated. Sometimes a surrogate of as a percentage of premium is used. The health plans typically refer to star ratings and quality measures, and the measurement of that. Watch your enrollment or attribution based on enrollment and counting membership months and continuous enrollment, which is really a critical factor when you come to HEDIS. Absolutely think about risk, whether it's total cost of care, what are the corridors, what are the caps, or what a stop loss. Can you buy the stop loss reinsurance, or does the plan need to do that? And definitely, if you're looking at total cost of care, find out or have the discussion about what are the exclusions, whether they're procedures, their services, their drugs, their age groups. All of that should come into your terminology and discussions. Mental health, behavioral health, and certainly new technology. Be very careful of what is included. Total cost of care, patient satisfaction, all come back to these kind of issues. As I said before, buying reinsurance. Network adequacy and leakage is typically where there's a loss of control of the contract, so be careful of that as well. I'm sorry, I have to go a little quicker as we're nearing 45 minutes, but so how do you negotiate? What are the do's and what are the don'ts? And this is following a theme that we had at our last presentation. Absolutely do your SWOT analysis, and especially on yourself. Memorize all the data and your benchmarks. Make sure you understand total cost of care and components. Make sure you do consider exclusions and caps. And then do your background research on payer. Quality and performance of the payer is a publicly available report on CMS's side. It tells you where CMS, based on the data submitted by the payer, where they stand in their stars rating and in their MLR. In some states, they even publish that. What are administrative costs, etc. Network adequacy is a little tedious, but it's all available because every payer has that published, and most clinically integrated networks and healthcare systems have that as well. So make sure you do a map and you match it. It requires a little bit of technology just to look at over visualization of that. Network adequacy is really important. And we've started to use a new term on that, is network efficiency. So you have a provider in the network, but nobody goes to that provider. What does that really mean? And make sure your approach is to do both. But the focus on access and quality, and then total cost of care. Do not make the mistake of the provider perceiving that you're it's all about money. So be really, really careful of how you do that. That's why I put that in bold. Definitely alternate meetings between home and away. Try not to have all the meetings at home, and definitely do not have all the meetings away. There's a reason why all our sports teams have home and away games, and how the results are measured and what the statistics show about what the teams do when they're home and what they do when they're away, even the color of the uniform. It's not a joke. There are certain colors that are associated with aggressiveness and performance. Be aware of these things. Definitely include your medical and nursing leadership in every conversation. They will watch for, sometimes you might have to educate them or get them prepared, but they will understand some implications of a program or a policy that the payer takes that you may not as an administrator. So definitely include them, and make sure you demonstrate both your technology that you have as well as the expertise to the payer, so they know they can't pull a fast one on you. Don't go unprepared. Don't go alone. If you don't have the staff with you, find somebody else as a subject matter to accompany you. Agree to take on services measures under your control. Absolutely, absolutely stay away from that. Reducing HbA1c is not under your control, because the patient can dictate what happens to their HbA1c. So be very careful of taking on or agreeing to measures that are not under your control. And we've seen that really a remarkable one recently was chlamydia testing for the 18 to 24-year-olds. The payer wanted one of our clients to meet a 58% threshold, and I was like, there is no way that's ever going to happen, because the patient is never going to admit to having a relationship. Plan to address all the measures and issues related to measures in one meeting. Do not try and break that up, even if that has to be a separate meeting, because the measures are intertwined. One impacts the other, so do not have separate meetings. Otherwise, you might lose track of a different measure discussed at a different point. And don't demonstrate flexibility on everything. Don't be a yes person on everything. You have to push back. Just as an astute negotiator, that is going to be something that we look for on the other side, is this a pushover, or are they really going to stand and take your stance or make your stance on things that matter to you the most. Again, it is the time for change. Do not negotiate without using data. I've listed a whole bunch of things here. It's something that you should be looking at, and the slides after this session would be made available. So please, please, please do that. Make sure you have all your data on your fingertips, and use the data to model. If you don't do any modeling of your own, you are really negotiating from the back of an envelope. And here's a model, and again, lack of time, but certainly guys, take a look at this. We think that as an ACO, as a provider group, the COVID impact is not as dire as some people have made it out to be. In this particular situation, if we've run COVID conditions where we have seen a reduction in total expenditure, and there are some counties that the expenditure has gone down to 50%. I've taken in this model a 35% factor of reduction. You can see that for these 13,000 patients, you're talking about a $9 million difference between expected and actual. And that could be a huge bonus for a risk-based agreement. Obviously, the payers are going to take a different approach to this and find a way to change rules in the middle of the game. And so will CMS. They're going to make sure that they see more of the savings than we do. So, but data modeling is very, very, very important. Make sure you have the expertise or get the expertise to model your data using your own information. That's the reliable information. Do not use the payer's data provided to you. It's CMS, it's really transparent, but for commercial payers, there are a lot of nuances where they don't give you paid amounts, they only give you charge data. So you have to model your own information. So data, modeling. Without that, you're not going to be able to have an effective SWOT analysis, both for yourselves and for the payers. Again, I'm sorry, I apologize, I had to run through these, but I'm going to stop here and open it up for questions. Garrett, are we good?
All right. Yes. Thank you. Thank you so much to both you and Dr. Yeager. We do have a few questions, and we have a little bit of time for them. We may have to. I don't know if we'll get to all of them, but I'll go ahead and begin in no particular order here. First question is, as a provider, what specifically should I rethink from a contract perspective?
Dr. Yeager, should I take that one?
Sorry. Yeah, I was absolutely. It'll apply exactly what you were just talking about.
I think that from a provider's perspective, if you haven't explored the downside, that's the first thought process. That's the first thing you should evaluate for yourself is what does it really mean? And that depends on your patient panel, your size, and the payer you're negotiating with. So that brief analysis or SWOT analysis on yourself and or on your entity as your organization, that's the first thing. Two is ask for data from the payer, and that would help you start your analysis. So that would be the second point, I would say. The third point would be realistic or be honest to yourself about your strengths and weaknesses. And I think those three things would be the steps 1, 2, and 3 to start considering moving to risk. If you've already done something as shared savings or upside only, look at your own data. Don't look at your shared savings and dollars distributed. Look at the statistics or your data on where we were talking about high risk, high cost inpatient care or facility-based care. See whether you've actually made an impact over time and make that an honest assessment for yourself, because that's one that we find is often missing.
I'm going to add just something to that, Dr. Seth. I agree with everything you just said. And the last thing you said touched on one of the things I was going to mention. And I think also how cohesive a group are you? So if you're a small group that meets together and you've got a lot of provider buy-in, a lot of support for moving the contract towards risk-based, and whether you have established guidelines already. If there's a process improvement context, environment where you are, and people are interested in taking on new guidelines and new processes, then there's the coordination of effort, I think, is important, and take a look at that in terms of whether you're ready to jump into risk-based or whether you would just start one-sided initially.
Okay. We have time for just a couple more questions here, and then we'll wrap up. The next is, aren't contract negotiations becoming more collaborative since payers and providers must work together on achieving value-based metrics and shared savings?
Absolutely. They are becoming collaborative, but there's still a negotiating stance. And so be prepared for having those discussions. Even if it's in a collaborative mode, make sure that you guys or both parties are talking about the same thing. and sometimes the perspectives are totally different. That collaborative nature typically doesn't come at the first negotiating stance. It comes later on when both parties realize that we're looking for the same objective, but that's not always the case. So you need to be prepared that you might be assuming that you're entering into a collaborative discussion where in fact somebody's waiting to take advantage of the weaknesses. So you need to be prepared. That's the point. It's not that it's not a collaborative, and as mature organizations with multiple contracts over a few years, it is absolutely collaborative. We're negotiating with a payer right now to say, the payer is saying, can we give you a list of providers that we would like you to recruit into your organization because you're doing well with us? So you're right, it is becoming very collaborative. In fact, it was a surprise, but we were still required, or we prepared ourselves should that have taken a different turn.
Okay, great. Last question here, and then unfortunately we're going to have to wrap up. But please continue to submit your questions during this time, because we will again get to them via email afterwards. For care management, if a patient is on 2 value-based care contracts, for example, Aetna and UHC, are both value-based contract important for reporting CM services? Or does the primary payer value-based care, the one to focus on for reporting? I'm not sure. Does that make sense? You want me to read that again?
I understand the question. It's rather unusual to see 2 primary care affiliations, but typically one primary affiliation with the one payer, and the second payer is really a secondary affiliation or a secondary payer. And entering into a value-based agreement with a primary and a secondary payer, I have not come across, but that's a really interesting question. In that, and typically we see that in the Medicare Advantage world, that could happen. With TRICARE, it happens more frequently. With the self-insured population for retirees, we see that, but I have not come across a individual patient being included into the attribution for 2 different payers. That is something that's rather unusual. So I'm happy to explore that with whoever asked that question, because I think that it's a unique situation. However, absolutely. First of all, you should be negotiating the same measures for all your contracts, because that makes it easier to manage the providers. Try not to have a different set of measures for each. So it makes reporting, and in this situation, if that was occurring, that would be easy. An easy solution is to have the same metric or the same measures included.
Okay, great. And that same individual who asked that question had a couple follow-up questions, but unfortunately we are out of time. So you know who you are, and we'll get back to you regarding that. In conclusion, and thank you both, Dr. Seth, Dr. Yeager. This was a very informative session. I got a lot out of it, and I think a lot of our listeners today did as well. As we conclude here, I would like to encourage you to visit the HealthEC booth at ACOexhibithall.com, which is what you're looking at here on the screen. And you can go to ACOexhibithall.com and you can look for their booth here. And that's a good place to connect with their team, learn a little bit more about them, what they're doing. You can request a demo there and connect with them there. Also, the ACOexhibithall.com is where you'll be able to find a link to the recording and to download the slides, and it'll be available in our reference library there. So, but of course, I will send you after the presentation today a direct link for you can do that. Lastly, if you have any specific questions for either Dr. Seth or Dr. Yeager, or the HealthEC team. Their contact information is here on the screen, so feel free to take a slide shot or a screenshot rather, and contact them directly, and they'll be happy to follow up with you for further discussion. So thank you all for attending. I appreciate you sticking around. I know we went a little bit long today, but I hope you found today's presentation very informative, very helpful. I know I did, and hope you have a great rest of your day. So stay safe. Thank you.
Thank you,
Thanks, Garrett.
everybody.